enthusiasts, welcome to the deep dive.
Oh, we're excited about this one.
You know, we love geeking out about all things knee, right?
Absolutely.
And today we're taking you on a journey.
Back in time.
Yeah, to explore the history of ACL surgery.
Fascinating stuff.
So going way back to the early days, trying to fix this crucial ligament and tracing how those surgical techniques have evolved.
All the way to today, to the cutting edge.
So what kind of intel are we dissecting today?
Well, we've got research papers, historical accounts, over a century's worth.
A century. Wow.
Our mission, should we choose to accept it, is to unearth those key aha moments.
I love a good origin story.
No, me too.
So let's rewind all the way back.
Okay.
Like late 1800s, early 1900s. Imagine those early surgeons, Ray.
I know, trying to figure out this torn ligament in the knee.
It's like, what do we even do with this?
Right.
Their first thought, repair it directly.
Just sew it back together.
Makes sense, kind of right. Like sewing a ripped piece of fabric.
Yeah, but think about it. The ACL is tucked away inside the knee joint.
Oh, good point.
Not easy to get to, let alone stitch it up neatly.
Yeah, not like a straight seam.
Exactly.
So early attempts at primary repair, like the one by Battle in 1900, had mixed results.
Yeah, Battle reported a somewhat successful case after 2 years.
Okay.
But then you have Mayo Robson claimed a successful repair, 8-year follow-up in 1903.
8 years. That's amazing for back then.
It is, but remember, these are just single cases,
Yeah.
The overall success rate, still quite low.
Makes sense.
And there was a lot of debate even then about whether primary repair was the right approach at all.
Ah, interesting.
Some surgeons, like Haygroves, he was already advocating for reconstruction.
Using a graft?
Yep, instead of trying to just stitch the torn ligament back together.
I see.
His argument was that the nature of ACL injuries, they often made direct suture almost impossible.
Oh, so even back then it was like repair or reconstruct.
It's a fundamental question.
That is.
Do you preserve the tissue or do you replace it?
It's this constant search for the best way to fix the knee.
Exactly.
Now, here's where it gets interesting. From the 1930s to the 60s,
Okay.
some prominent surgeons, get this, they questioned the need for ACL repair at all.
What? Really?
They thought if you just dealt with the meniscus and capsular injuries, that the knee would be stable enough.
Hard to believe now, right?
Seems crazy now. We know the ACL is crucial for rotational stability.
But back then, the understanding of its role, well, it wasn't so clear.
Yeah, they were still figuring out all those knee biomechanics.
Exactly.
It'd be like trying to fix a car engine.
Without knowing how the parts work?
Right. And they didn't have the imaging we have today, right?
Nope.
So they couldn't really see the damage.
Or predict the long-term consequences.
Yeah, they had limited tools, limited knowledge. It's understandable that things change as they learn more.
Absolutely.
Okay, fast forward to the early 1970s. There's a renewed interest in primary repair.
Okay.
It's fueled by the surgeon, Fagan.
Fagan, yeah.
And he had some initial success with repairs on West Point cadets.
West Point. Those guys are tough.
Yeah, so his results seem promising. And then there's McIntosh.
Oh, McIntosh. He loved to tinker.
He developed this, what they called the over-the-top repair technique.
Sounds pretty intense.
It did seem like primary repair was making a comeback.
Yeah.
But, like they always say in medicine,
more research is needed.
Exactly.
And more research show that those early results didn't hold up over time.
Oh, so even with the new techniques, primary repair still couldn't consistently give you long-term stability.
It was back to the drawing board. By 1970, the focus had shifted to reconstruction.
To reconstruction, okay.
The shift was driven by research, all that scientific work on knee instability.
Makes sense.
Researchers like Slocum and Larson, they started talking about rotational instability.
Rotational instability, got it.
They were highlighting those complex biomechanics.
Right.
So around this time, surgeons start developing procedures specifically designed to control that rotation.
To prevent, like, the tibia from sliding forward too much.
Exactly. They were trying to deal with the consequences of a missing ACL, not fix the ACL itself.
I see. So, like, stabilizing a wobbly table by reinforcing the legs instead of fixing that loose joint at the top.
Perfect analogy. They were focusing on the symptoms, not the root cause.
Gotcha.
Now, some of these procedures were pretty ingenious.
Oh, yeah. Like what?
The PP and Serenus transfer, they basically rerouted tendons to work as internal rotators.
Interesting.
And then there was the Nicholas 5-in-1 technique.
5-in-1? That's a lot.
Oh, yeah. It was a combination of procedures to address different aspects of instability.
Wow, that's intense. Did they throw in a free knee massage with that one?
Maybe. But you see, while these procedures aim to reduce the rotational instability, they often came at a cost.
What do you mean?
Patients were immobilized for weeks.
Oh, no.
Flexed knee, internally rotated.
Ugh, that sounds stiff.
Oh, it led to a lot of stiffness, loss of motion.
So they fixed one problem.
And created another.
Exactly.
And importantly, they were still not really dealing with that torn ACL directly.
They were dancing around the issue.
Like trying to fix a leaky faucet by just mopping up the water.
Instead of actually tightening the valve.
Exactly. A temporary fix at best.
Okay.
But here's the turning point. 1971.
Big year.
Big year for knees. Kennedy and Fowler, they published this groundbreaking anatomical study.
Ooh, that mattered.
Their research showed that the ACL could be injured all by itself. No other structures involved.
So it wasn't always part of a bigger injury.
Nope. And that was a game changer. It challenged that old way of thinking.
I see.
The ACL was finally getting the recognition it deserved, crucial for knee stability. It's like realizing that a small crack in a building's foundation
Could bring the whole thing down.
Exactly.
Makes sense.
And this new understanding, along with Galway's description of the pivot shift,
Right.
it led to a refined theory of rotational instability.
So after years of focusing on everything else, they were finally zeroing in on the ACL.
It's amazing how science sometimes catches up with what surgeons are seeing every day.
True.
So this led to a wave of procedures, all aimed at limiting that anterior subluxation of the tibia.
Yeah.
They were getting closer to the source of the problem, but still working mostly with extra-articular techniques.
So still manipulating those structures outside the joint itself.
Right. They were still working with the IT band, trying to use it to stabilize the knee.
The IT band, I've heard of that.
Macintosh, for example, he adapted his procedure and developed what we call the Macintosh 1, which was passing a strip of the IT band through the intermuscular septum under the lateral collateral ligament. Other surgeons, Luzzi, Ellison, Andrews, they all developed their own variations.
So lots of experimenting.
Oh, yeah. It was a period of incredible innovation. Each surgeon trying to biomechanically control the knee in a different way.
It reminds me of like how different artists would paint the same landscape,
Oh, I like that.
bringing their own style to it.
Absolutely.
But as in art, not every experiment is a masterpiece.
Sadly, that's true.
These laterally based procedures,
Uh-huh.
they eventually fell out of favor.
The results are inconsistent.
Yeah.
And there was a high chance of arthrofibrosis, too much scar tissue in the joint.
Ouch.
Plus, there was that risk of varus instability, where the knee buckles inward.
So innovative, but not the perfect solution.
Not quite. They weren't consistently giving that long-term stability that patients needed.
Yeah.
They needed a new approach, one that directly addressed that ACL and minimized those side effects.
You needed to go deeper.
Exactly. So, ready to go deeper.
Let's do it. Where were we?
Surgeons were starting to realize,
Yeah.
directly addressing that ACL was key to getting that lasting stability.
Right. They'd tried those extra-articular techniques.
But they had those downsides we talked about.
Exactly.
And, like often happens in medicine,
Yeah.
a big breakthrough came from the research lab.
Oh, the lab. Tell me more.
In the 1980s, researchers like Noy,
It's okay.
he definitively established the ACL as the main thing preventing that anterior tibial subluxation.
So basically proving how important the ACL is.
This was huge. It solidified its role in knee stability,
Okay.
and it paved the way for a whole new era of surgical techniques.
Inter-articular stuff.
You got it.
Okay, so finally the evidence backed up what they were seeing.
Right, and they could confidently shift their focus to those intra-articular reconstructions.
Meaning they were going to actually replace the ligament, right?
With a graft placed right inside the joint.
Got it.
Think of it like this. Instead of just propping up that wobbly table leg from the outside, they were going to fix the loose joint at the top.
They went to the source.
It was a total paradigm shift.
So who were some of the pioneers of this intra-articular approach?
Well, there was Insall, for one.
So,
He developed this dynamic technique, still using the IT band, but threading it through the joint, fixing it to the tibia.
So IT band was still in play.
Yeah, but now it was an internal fix. It was replacing the ACL.
Interesting.
And Macintosh, remember him?
Oh, yeah, the IT band guy.
He was always tinkering. Well, he embraced this intra-articular approach, too.
Okay.
Modified his procedures, developed what we now call the Macintosh 2 and 3.
Those names.
They really emphasize the importance of placing that graft correctly.
Anatomically correct.
You got it. It's like they were finally understanding the knee as this intricate work of art.
I like that.
Every structure has its place, its purpose.
Like a well-oiled machine.
To restore that function, you have to respect that original design.
Absolutely. So what about the material for these grafts? What did they use?
Well, they kept working with the IT band for a while.
Okay.
But they also started exploring other options, like the patellar tendon.
The patellar tendon? Oh, yeah, I remember when they used to harvest a portion of that.
You've seen your share of those grafts, I bet.
Oh, plenty on x-rays. That was a common choice.
It was popularized by Clancy. He took a section of the tendon with a bit of bone from the patella and the tibia.
So bone patellar tendon bone graft, BPTB.
That's the one.
Got it.
And it provided a really strong replacement for that torn ACL.
And how did the BPTB grafts perform numbers-wise?
Oh, they showed great results for stability and getting that knee function back.
Excellent.
But of course, surgeons never stop exploring, right?
Always innovating.
Always looking for better options.
Makes sense. What else did they try?
Some even experimented with using the medial meniscus as a graft.
Wait, the meniscus?
Yeah, back in the early 70s.
But the meniscus is so important for shock absorption and all that.
I know, right? It seems counterintuitive.
It does.
But, well, those meniscus grafts didn't really work out.
Didn't live up to the hype?
Nope. They weren't as good as those patellar tendon grafts.
But it shows you that they were willing to, think outside the box.
Absolutely. Always pushing the boundaries.
So what about hamstring tendons?
Ah, yes. Hamstring grafts. They actually made a comeback around this time.
Okay.
Surgeons like Zarins and Rowe, they refined the technique using the semitendinosus tendon, combined it with a Macintosh 2.
Macintosh strikes again?
It provided excellent stability, but it was a more extensive dissection.
So more potential complications.
Yeah, there was that risk.
So always trying to balance the benefits with the risks.
Always a tightrope walk, right.
Exactly.
Now, while they were making progress with these intra-articular reconstructions using the patient's own tissue, another chapter was unfolding, a really interesting one.
Ooh, I love a good plot twist. What happened?
The era of synthetic grafts.
Synthetic grafts, like artificial ligaments.
Exactly. They thought synthetic materials could be the answer.
Okay.
A strong, readily available alternative.
No need to harvest tissue from the patient.
You got it. And they thought they might even be stronger than natural tissue.
Makes sense, I guess.
But, well, as they say, if it sounds too good to be true.
It probably is.
Exactly. These early synthetic grafts, they were made of things like polyethylene, Teflon, carbon fiber, polypropylene, all sorts of things.
Wow.
But they all had the same problem. They just couldn't match the durability of natural tissue.
Oh, no.
They stretched out, fragmented, and eventually, well, they just failed.
So back to the drawing board.
In a way, yes. As surgeons got more experience with those autografts.
The BPTB, the hamstrings.
The appeal of synthetics faded.
They realized natural was better.
Sometimes the old ways are the best ways, right? And just when they were getting comfortable with those refined intra-articular techniques, a new revolution was coming.
Ooh, tell me.
Arthroscopy.
Arthroscopy. Now we're talking. This is where ACL surgery starts to look like what we see today.
Exactly. The early 1980s, that's when it all changed.
Where really revolutionized everything.
The surgeons realized they could do those intra-articular procedures we talked about, but arthroscopically.
Through those tiny incisions.
Tiny incisions, specialized instruments.
It's amazing.
Game changer. Instead of big open incisions, they could access the joint through those little keyholes.
Much less trauma.
Way less trauma.
So what happened to BPTB and hamstring grafts?
Well, they became even more popular.
Ah.
Surgeons could harvest and implant them so much easier, faster recovery, less pain, smaller scars.
It was like trading in a sledgehammer for a scalpel.
Precisely. Same goals, but with so much more finesse.
So at first they were still doing those two incision techniques, right?
You're right. But over time, they got even better.
Better how?
They developed special drills and fixation methods
Uh-huh.
so they could do the whole reconstruction through just one incision.
Wow.
It's incredible how technology can drive those innovations.
Absolutely.
It's like watching an artist refining their technique over time.
Getting better and better.
Exactly. Those masterpieces became less invasive, more accessible for patients.
Everyone wins.
A win-win. But even with those advances, the quest for that perfect ACL reconstruction, it didn't stop there.
Of course not. Surgeons are always striving for better.
Always. They started delving deeper into the anatomy, realizing that precise graft placement, that was key.
To restore those natural biomechanics.
You got it. It wasn't just about getting the graft in there. It was about putting it in exactly the right spot.
Yeah, to mimic the original ACL as closely as possible.
Absolutely. But, like any journey of discovery.
There were bumps in the road.
Oh, yeah. Early on, surgeons often put those tunnels for the graft too far forward.
Oh, no. What happened?
It caused the graft to impinge on other structures in the knee.
Ouch.
Pain, limited motion, even graft failure.
So they learned from those mistakes.
That's how we get better, right?
Trial and error.
Exactly. Through research and lots of trial and error,
Yeah.
they figured out that ideal placement for the tibial tunnel.
Where is that?
Posterior aspect of the footprint, about 6 millimeter anterior to the PCL.
6 millimeters. That's precise.
And they even developed better tibial tunnel guides to help ensure that accuracy.
Like using a ruler instead of eyeballing it.
Exactly. Precision tools for a precise job.
Makes sense. What about the femoral tunnel?
That one presented its own challenges.
How so?
Especially with those all-inside arthroscopic techniques, they had to get that posterior placement, but without drilling right through the back of the femur.
That's tricky.
It is. It's like threading a needle through a keyhole, but from the inside out.
Delicate work.
You said it. But surgeons, they're clever.
What'd they come up with?
They invented the femoral over-the-top guide,
Okay.
or the posterior offset guide, as it's sometimes called.
And this guide, it helped them get that precise placement.
Without compromising the bone. They were constantly innovating, coming up with new tools and techniques.
They're always improving.
Always. And it wasn't just about the location of the tunnels, it was the angle too.
The angle.
Especially for those BPTB grafts.
Okay.
The sagittal and coronal plane angles, they were crucial.
So it was a real three-dimensional puzzle.
It was. And one of the challenges they faced was graft tunnel mismatch.
Mismatch? What's that?
Sometimes those bone plugs on the BPTB graft,
Yeah.
they didn't line up perfectly with the tunnels.
So it's hard to get a good, secure fit.
Exactly, like trying to fit a square peg into a round hole.
Not going to work.
Nope. So they had to come up with strategies to address that mismatch.
Like what?
One was this formula, the N+7 rule.
N+7 rule. Okay, I'm going to need you to break that down for me.
Sure. Imagine your patellar tendon graft as like a piece of string, bone plug at each end, right?
Okay.
N is the distance between those bone plugs.
Yeah.
You add 7 to that, and that number, that gives you the ideal angle for your tibial tunnel.
That's pretty clever.
It is, right. And they also tried other things like shortening the graft, recessing it within the femur, even using extra-cortical tibial fixation.
So lots of options to make sure it all fits snugly.
A whole toolbox of techniques.
Now, what about those who were using the soft tissue grafts, the hamstring tendons?
Good question. They had their own set of challenges.
Fixation.
You got it. Remember, those soft tissue grafts, they don't have those bone plugs.
Right, like the BPTB has.
So they had to find other ways to anchor them in the bone tunnel.
I see. So how'd they do that?
Initially, they relied on techniques like over-the-post fixation and early endo-button designs.
Those are like little buttons that held the graft in place.
That's a good way to picture it.
But didn't those have some problems?
They did. Research showed that fixing the graft too far from the joint could make it looser.
So they needed to get closer.
Closer and more secure. They started using modified screws and these bicortical fixation devices, cross pins.
Cross pins, okay.
They provided stronger fixation right near the joint.
Stronger material, stronger hold.
Exactly. They were constantly refining, paying attention to those little details that could make a big difference in the long run.
It's all connected.
It really is.
Okay, so even with intra-articular grafts and arthroscopy, there were still nuances that could impact outcomes?
Oh, absolutely.
Like what?
One thing they found was that vertical femoral tunnel placement in those single incision techniques, well, could be a problem.
What's wrong with vertical placement?
Well, it provided good anteroposterior stability,
Yeah.
but it wasn't so good for rotational stability.
Ah, right. Rotational stability, key to preventing those twisting injuries.
Exactly. They realized that they needed a more horizontal graft orientation.
Get that rotational control.
Oh.
Makes sense.
And to achieve that, they often used additional portals like the interamedial or transpatellar portal.
Getting a better angle, I see.
Exactly. They were always finding ways to improve, looking for that perfect balance.
Between stability and function.
You got it. Like artists, always fine-tuning those brushstrokes.
Creating a masterpiece.
Precisely. And that brings us to today.
The present day, with all its cutting-edge techniques.
Like double bundle reconstruction.
Ah, yes. The double bundle. Tell me everything. All right, knee enthusiasts, welcome back to the deep dive.
We're in the home stretch now.
As we wrap up this epic journey.
Through ACL surgery history.
I'm just amazed by how ingenious these surgeons have been.
It is inspiring, isn't it?
The perseverance, the constant drive to improve those techniques.
Oh, absolutely. We've come such a long way.
From those basic repairs,
Stitching it back together.
to these minimally invasive procedures.
They're so precise.
It's remarkable.
And all driven by a deeper understanding of how the knee works.
Right, the anatomy, the biomechanics.
It's like those early surgeons were working in the dark, almost.
Yeah.
And with each discovery, they got a clearer picture.
The clearer picture.
Of how to treat those ACL injuries effectively.
Those early studies.
Oh, yeah.
The research on rotational instability, graft testing.
They all shaped the approaches we use today.
It's a perfect example of how science and surgery, they work together.
Hand in hand.
Now, speaking of beautiful, I'm really impressed by those modern arthroscopic techniques.
I know.
It's like the way they navigate that joint through those tiny incisions.
I always say it's like watching a microscopic ballet.
You and your analogies, I love it.
Well, you know me and art, but even I have to admit, there's an elegance to these minimally invasive approaches.
There is.
The precision. We've come so far from those days of big incisions and weeks of immobilization.
Right. Less pain.
Faster recovery.
Smaller scars.
It's a win-win.
It really is. And don't forget the psychological benefits.
Oh, absolutely.
When patients can recover quickly, get back to their lives.
It's a huge difference.
Huge. It impacts their whole well-being.
Exactly.
So it's not just about, like, fixing a knee. It's about restoring their quality of life.
And that's what makes this field so rewarding. Yeah.
It does. And as we look ahead,
the future.
I'm excited to see what research brings us next.
Oh, me too.
Even better solutions
for
ACL injuries. Double bundle reconstruction, that's a great example.
It is. It really shows that ongoing pursuit of excellence.
Now, you talked about double bundle reconstruction before.
I did.
Can you remind us what makes it so special?
Sure. Double bundle reconstruction, it's all about recreating that natural anatomy of the ACL in even more detail.
Okay.
Remember, the ACL isn't just one thing. It's got two distinct bundles.
The anteromedial and the posterolateral. You got it.
And they each control different movements of the knee, right?
Exactly. So instead of using one graft for the whole ACL, double bundle reconstruction uses two.
Two grafts for each bundle.
Yep. It's like recognizing that a masterpiece isn't just one brush stroke.
Oh, I knew you'd bring art into it.
It's a combination of many carefully placed strokes.
To create that whole image.
Precisely.
Makes sense.
Yeah.
So with double bundle, you're trying to more accurately restore
the stability.
Right.
Both anteroposterior and rotational.
Okay.
It's fine-tuning those knee mechanics and potentially, leading to better long-term outcomes.
Now, single bundle techniques, those were producing pretty good results, right?
They were.
So why the need to go even further?
Well, even though patients were doing well functionally, biomechanical studies show that those single bundle grafts, even when placed perfectly, they might not be restoring normal knee motion 100%.
So even though the knee felt stable, there were still subtle differences. Subtle, but maybe important in the long run.
Okay.
Some surgeons worried that those altered mechanics, well, they could lead to problems later, like osteoarthritis.
Because of increased stress on the joint.
Exactly. So double bundle. It's not just about stability, it's about getting that natural movement back as closely as possible.
Striving for perfection.
Always.
So what does the research say about double bundle so far?
Well, it's still early, but there are some promising results.
Promising how?
Studies show that it can improve rotational stability compared to single bundle.
Okay.
And some even suggest that patients report better outcomes.
That's great. But it's still a pretty new technique, right?
It is. And it's definitely more complex, technically demanding.
So more challenging for the surgeon.
Definitely. And there's a potentially greater risk of complications.
So it's not a decision to be made lightly.
Exactly.
Yeah.
Surgeons need to consider each patient individually,
Right. Their activity level, how severe their injury was.
All those factors. It's all about personalized medicine, finding the right solution for each person.
Makes sense. And that highlights how important communication is, right?
Oh, absolutely.
Between the surgeon and the patient.
They need to discuss those pros and cons, make the decision together.
Shared decision-making.
Crucial for any surgery, but especially for something as complex as this.
Absolutely. So where do you think ACL surgery is heading? Will double bundle become the new gold standard?
Tough question. There's a lot of buzz, a lot of potential.
Yeah.
But we need more research to really know for sure.
It's an exciting time to be a knee geek, that's for sure.
It is. I can't wait to see what the future holds.
Triple bundle, quadruple bundle, who knows?
Maybe.
But for now,
yeah.
let's wrap up by acknowledging how far we've come.
Yeah.
Right.
From those early repairs to these amazing reconstructions.
It's incredible. It's a testament to human ingenuity.
To that drive to help patients.
Exactly. To help people regain their mobility,
go back to their lives.
And live life to the fullest.
Well said.
So to all our knee enthusiasts out there, keep those knees healthy and strong.
Yes.
And if you do end up with an ACL injury, know that there are amazing surgeons and researchers to give you the best possible care.
Absolutely.
The history of ACL surgery shows us that innovation never stops.
Never.
So stay informed, ask questions, and be involved in your healthcare.
Couldn't agree more.
And that's a wrap.
On another episode of The Deep Dive.
Thanks for joining us on this Needventurous, yes, exploration of ACL surgery history.
Don't forget to like, subscribe, and hit that notification bell
for more deep dives into the world of knees.
And until next time,
keep those knees happy and healthy.
See y'all soon.